So you have the meeting in front of you. You should have an icon, a pop-up box that tells you to, offers you the option to accept the fact that this is being recorded, and please be mindful of the protected health information, the PHI, your personal information that you are sharing in the meeting. So I will remind people that if you are online and can use the attendance link, you see it on the screen. And I would ask Jessica, perhaps if you can place it into the chat, that would be great. The attendance, thank you. And perhaps, Jessica, if you can scroll down a bit to see the agreements. Page 2. There we go. Thank you. So, folks, these agreements were put into place years ago by stakeholders because, and they've been edited a little bit here and there by stakeholders over the years to deal with certain situations we've had in terms of people's behavior in the meeting. Folks who are on the phone other than me, if you can hold on for a minute, please. I just want to point your attention to this list. You should have a copy of the agenda if you are online. If you have email, if you received it through the snail mail, you can review it. I think the principle here is that we are asking everyone to be respectful of each other, stay on task, stay solution focused, and understand that we don't all agree on the various important topics that we have before us in these meetings. If something occurs that we go off from that, I will, as facilitator, step in and stop the action and bring us back to a point where we can proceed. I do want to mention housekeeping, and we can go back up. Thank you, Jessica. I want to mention that if you are, we are going to do our very best as a staff team to make sure that folks who are not speaking are muted. You can help us to do that by pressing *6 if you are not muted. Otherwise, the meeting will grind to a halt and we will need to stop the action. So we want to hear from everybody. And one way to do that is to keep background noise to a minimum. So again, attendance online. Now what I'm going to do is to go over and find out who's there, who's just on the phone. Ron Heller, I hear you. I have heard you already, so we have your name for attendance today. We're all good with that. Dolores Hurley, heard your name. We have you down for attendance today. Is there anyone else who's just on the phone?
John, Tracy might be a little late today.
Okay, thank you.
Thank you.
All right. Anyone else?
Kathy Estes on the phone.
Thank you, Kathy. Kathy Estes. Anyone else? Okay, I will make a note to come back to that before the break or around the break time. Thank you. So now I am at a bit of a loss here that I need to pull up the chat. Bear with me. There we go. So I am taking names now for people who have an item for the first open forum. You can type your name into the chat. The open forum, by the way, is for announcements. We do have a mechanism to suggest agenda topics, which I'm hoping at some point during the meeting, Aaron will go over again. We talked about that, I believe, for the first time in our last meeting, but this could also be to recommend a topic for the agenda for future, and also to put forward a question, share information with your peers. Let's see, anyone for the open forum? Julie, I see your name there, thank you. Anyone else?
John, if I can be added.
Who's that?
This is Jessica Corral, John. Thank you.
Got it. Okay. Anyone else? Okay. We will proceed then, and we will start with Julie Riskin. Julie, please go ahead.
Thanks, John. I actually have two. One is just some sad news that Brian Miller, the son of Debbie Miller, who was part of this group for a long time, passed away last week. So I just wanted to let people who have been around know that, just in case they wanted to reach out to Debbie. I don't know anything yet about services. It's been a few days since I've talked to her. So that was just, I just wanted to let people know that. And then I haven't been able to do the minutes for the past several months, but I also realized that I don't know that they're needed anymore now that we're doing these online and recording them. So I think just recording them, because no one else has really seemed willing to do them. And I'm just not always available to both be here and then spend the time kind of getting them ready. So I just wanted to announce that. If people think they're important and someone else can do them, then that's awesome. Otherwise, I think the recording will do.
Okay, thank you, Julie. And I'm going to now pause and see if there's anyone who would consider taking on doing the minutes. It doesn't necessarily mean doing them today, but you could do that. So if there is anyone, you can type your name in the chat, a brief statement that you are interested in learning about doing them. Or you can contact me, John Barry, by email, phone, etc. I will put my phone number into the chat when I have a moment for you to do that. And while we're at it, then I will just say, I think it needs to be said that Julie is one of the stakeholder volunteers who's been volunteering to do the minutes for years, several years, many years. And it was an agreement, it was a request by stakeholders years ago that the minutes be done by stakeholders. And we, the department, have adhered to that. What we were asked to do recently, given Julie's very busy schedule and absences, was to record it, and we're doing that. And those recordings are all on our webpage. I will, when time allows during the meeting, I will post that as well in the chat, although I do believe that that link is somewhere on the agenda item. So, Julie, on behalf of everybody, I would just say thank you for all you've done in that regard. So let's see, we have other stakeholders who are in the open forum, and I will go to them first and then come back to staff. Kurt Wolf.
Hey, John.
Yeah, go ahead.
Hey, so I've been out for a little bit. First, I want to, again, thanks, Julie, for all your minutes and things you've done. And I think I'd like to just ditto the recordings. On another note, I've been out for a few weeks due to some unforeseen circumstances. I'm getting better. I just want to throw out kudos out to Rocky Mountain Human Resources. I needed extremely additional time due to some injuries and things I had done. And just telling everyone, be persistent with your managers, keep their numbers handy. She has managed to work things through Intelligent, I believe, is the one with the medical issues. So I just want to throw out that the system works. You got to make sure you make your phone calls. So thank you, Rocky Mountain Human Services.
Okay, thank you, Kurt. This is John again, and ditto other people. It's great to hear your voice. Great to have you back with us. We will go next to Robin Bulldog. Robin.
Okay, I got it. Oh, that's so funny that Kurt said the system works. I'm involved with 3 cases right now where the system's not working. And one is around CDASS. And one of the issues really is addressing folks with really complex needs. And I asked to have an agenda item. I understand our agenda is really full around support brokers. And I'd love to see a presentation on what other states are doing with, well, what a support broker is, what other states are doing around support brokers in consumer direction. And I really think that is probably the one place Colorado's behind other states in that we don't have that option available to folks. So someone besides a case manager, someone who's a third party that can help folks navigate getting onto CDASS. And and that seems to be what I'm seeing is folks getting onto CDASS with complex needs are really having a lot of issues. And I think a support broker that specializes in that would be really helpful. Our case managers are overworked and they're supposed to be experts in everything, and it's just not working. They can't be experts in everything. So, so again, I'll make the request. I did ask for, I did go through the website. I asked for this to be on the agenda, and it's not this month, and I understand.
Thank you, Robin. We have a couple of staff who have asked for a moment. Let's see, Heather Johnson.
Thank you, John. I just wanted to take a quick few minutes to let folks know that the individual grant is open. This would be for direct care workers, folks working in those hands-on positions. It's a reimbursement-based grant. The maximum award amount is $500. You can apply for it as many times. You just have to complete one cycle before you apply for the other. And so this would be for training that is outside of your typical onboarding or annual training to work in direct care. So the goal is looking for providing higher level skills or some specializations. So I will drop a link in the chat to the website. There is an application in there and a lot of information about it. So I just wanted to let everyone know it is open and ask that they share the word with others, just in case this might be an opportunity that somebody could take advantage of. Thank you.
Thank you, Heather. I see that we have a stakeholder, Jerry Frye, who has raised her hand. Do you have an item for the open forum, Jerry?
Yes, I just wanted to respond to Robin Bulldog's suggestion about a support broker. And I would like some process within our participant directed, PDPPC meeting, how to go about getting a support broker addition to the consumer directed option. How do we actually do that? And maybe before the second forum at the end of this meeting, someone can suggest or somehow move forward the concept of support broker, or as an alternative, make sure that it gets on the agenda for next month. Thank you.
Thank you very much, Jerry. I'm going to channel Aaron Thatcher here and say that anything of this nature would, I believe, most often begin with a written recommendation by the PDPPC. And that process is very well known. The stakeholder co-chairs, Kevin and Kurt, can answer any questions from stakeholders about that, as can staff, but it is a stakeholder function. So I believe that would be a first step. Thank you. So now we will go to Jessica.
And can I respond in a second? It's Robin. It was my topic.
Sure, Robin, go.
Okay. Okay. So now I'm confused that it had to be a recommendation. If it has to be a recommendation, then we need a subcommittee. I thought we could put things on the agenda. I'm not sure everyone on here knows what a support broker is. And so I was asking for it to be put on as an agenda item for a short presentation, and then we can, move forward with a recommendation. My concern is everyone doesn't know what a support broker is that's on here. So I think we all need to make informed choices. So that's why I asked for it to be on the agenda. I mean, if you want to create a subcommittee today, I'm good with that too.
John, I got a ditto Robin on that. I mean, that's something maybe we talk about at the what the agenda should be at the pre-planning meeting next in 2 weeks. So I think we're right at really step one of that. So I just want to add thank you, Robin. All right?
Yeah, absolutely. I guess I was responding to Jerry saying she wants to see it be part of the program, but I will defer to Erin, who has her hand. Erin?
Oh, goodness. Excuse me. Good afternoon, everybody. This is Erin Thatcher with the department. Robin, thank you for reminding me that you put your information into our request form. We did receive it and it's very new. So we're trying to incorporate it into our planning meeting. So the one that we have with Kurt and Kevin at next week. So I definitely think we can get it on the agenda next week, but I do want to just share everybody that we have a community first choice subcommittee happening right now, and we had 2 meetings about support broker. So we can definitely discuss that again here, but I think I would just recommend to everyone, if you're interested in where CFC or community first choice is going and you have input about support broker, that you let us know so that we can incorporate your feedback into what we're hoping to do. And I totally agree with everyone that says, you know, it might be needed and we are missing some things, and that's where we need your participation and help. So Christine Desantos will be on the agenda a little bit later to talk about the CFC meetings that we've been having. So anyways, all of that to be said, we do have a form that I'll go over in a minute about requesting topics. And then of course, anybody can make a recommendation. Those 2 things don't have to be mutually exclusive. So thank you, John.
Thanks, Erin. We have time for one more for this. And again, remind everyone, we have another open forum before the meeting ends. So Jessica Corral.
Thanks, John. Hi, everyone. This is Jessica. I just want to call attention to 2 of the documents that went out with the PDPPC materials. They're invitations to 2 stakeholder engagement events related to the RFP process, the request for proposal process that will be underway very soon. This process is to procure new vendors, FMS vendors, and a training and operations / support vendor for a new 5-year contract term starting in 2024. So this will be a listening session in the evening. We tried to be accommodative to people's schedules, 5 to 7 p.m. on the 6th for FMS specific conversation, and then 5 to 7 on March 13th for training and operations contractor. It is a virtual meeting, but there's a call-in option, toll-free call-in option. And the agenda was posted in the materials John sent out. On that form, you can express your interest in joining us for that listening session. It is a Google form. So if you do not have access to that, then you can give me a call. I'm happy to jot your name down and answer any questions that anyone might have. My number is 303-866-3504, 303-866-3504. And I'll put that in the chat. I really welcome individuals to come, and I want to make clear that this is specifically for program participants, advocates, current or prospective contractors will not be participating in these listening sessions, but there will be opportunities to provide information and receive feedback for those entities via various other methods.
Okay, thank you,
Thank
Jessica.
you.
So we will move forward again. There's another open forum later. Erin, stakeholder topic request options.
Sure. Thank you, John. And thank you, everybody. I know we mentioned this last month, but we've got some new people, and I do want to share that this is an option. So in order to help the planning committee, which is really the PDPPC co-chairs, so Kurt and Kevin, as well as John Barry and the department staff that participates. We developed a stakeholder topic request form that is online. However, that being said, we're happy to take phone calls or any kind of communication from you to us or the co-chairs about agenda topics. One thing that I think is really important here is that we don't forget about things, which Robin, I will admit, we forgot about you. So I owe you one. I want to make sure that we are ensuring that our co-chairs are aware of issues and what kind of times are needed to talk about things during a meeting. If there are materials to send out, we want to get those to John so we can mail them. So all of that stuff takes time, and we need to be pretty well coordinated to do that. So I'm hopeful that next planning meeting we'll have some additional items from all of you. The Google form is, I'm going to put a link in the chat here. It's a Google form and you can complete whatever you need to, and it can be just an idea. It doesn't have to be fully thought out. But if you want to hear about, I don't know, like your favorite color turtle or something, we could probably table it for another time. But that being said, I think I'd ask that if you do have a topic you'd like to request at PDPPC, that again, you fill out the form or you contact one of the co-chairs or John Barry or one of the department staff so we can make sure we get all the details from you. Any questions from anyone?
Folks, if you have a question, you can put your name into the chat, or if you're on phone only right now, you can unmute your phone. Any questions for Aaron? Comments, questions? Seeing none so far, Aaron?
Okay, great, thank you. And if you have feedback on how this form looks, or if you hate it and you'd like us to do something different, please let us know. It's here for you, and it's here to help streamline the process and really make sure we're not forgetting about things, because even though we meet monthly, sometimes we have really short memories. So thank you, I appreciate that. And I think we can move on to the next topic.
Okay. We are running a bit early for that, so I'm not sure if any of the CFC team are here.
I'm here.
That's a question. Oh, excellent.
Hi, John.
Hi, Christine. Please go ahead.
Sure. Hi, everyone. Christine Desantos from the department. I'm with the CFC team as well as the Participant Directed Programs Unit. And I'm here to give a little update on CFC as well as the work that the work group has been doing. As a reminder, we did talk about this at our last meeting as well as I think the one before. We do have a work group that will be collaborating with the department on some specific policy changes needed for implementing consumer-directed attendant support services in community first choice benefit. So we did have our first 2 meetings in February. We had a total of 27 members attend, or 27 participants in that work group. And our first topic was information and assistance. So the work group reviewed some research information related to what information and assistance are, INA, how currently Colorado conducts INA in CDASS, and also we discussed some other states, how some other states have implemented INA, including support broker models. The department did share that due to an abbreviated timeline and many large projects, including case management redesign and the implementation of the new care and case management system, we intend to keep the structure of CDASS vendors largely the same at this time. And so the department intends to procure 1 training and operations vendor which they will do. They'll continue with training for members, ARs, case managers, and IHSS agencies. They'll also continue to do operations that's for support of our self-directed programs. And in addition, we want to, and we were looking to investigate or to add some potential support broker activities to that contract. So basically expand that scope of work to include some additional activities that would help fill in the gaps, as noted by a couple of participants here today. There are some gaps in all of our vendors around CDASS. So what we did is we discussed as a group what kind of additional activities might be added to that vendor contract to help support our members as we expand CDASS within Community First Choice. Some of those things that we talked about were Medicaid resource navigation and community resource navigation. So that's assistance with housing, ESL, or English as a second language, food assistance, et cetera. Assistance with emergency backup planning, monthly allocation utilization coaching, and assistance with attendant recruitment and retention. So we did talk about at that meeting what we thought was important and where we thought some of those gaps might be. As Erin stated, we welcome more feedback. So if you were not able to attend that meeting, I'm going to put my email in the chat for everyone. Please reach out, provide whatever feedback you're interested in providing, and we'll get that integrated into what we have already gathered through the work group topic. And then, so any questions about that first, and then I'll talk a little bit more about future meetings and where to access information.
So this is John. If you have a question or comment, you can put your name in the chat to enter into the queue, or if you're on the phone, you can unmute right now. Christine, do you see one question from the chat already? When is CFC expected to be implemented? From Oliver.
Thank you for that question, Oliver. At this time, we are anticipating implementation for July 1st, 2025.
Any other questions, comments about Christine's topic? Okay, there doesn't seem to be any more right now. Thanks,
Okay.
Christine.
Great, thanks. So in the future, we will be doing we'll be putting this summary that we'll also be providing during the meeting, but we're also going to put it up to have access on our website, on the CFC Stakeholder Opportunities website, so that you'll be able to click there and find the agenda for the meetings coming up or previous meetings, slides, if there was any slides or other materials provided, as well as a summary of the meeting. We will also be providing that information with the PDPPC materials that get mailed out and emailed to the members of PDPPC. So you should be able to get access to those documents even if you don't have access to the internet. And then if you're interested in attending, our next meeting is scheduled for March 9th, 2023 from 1 o'clock to 2:30 p.m. And we will be discussing during that meeting unstable health, or supporting members in unstable health. And again, I'll also put the link for the interest form. If you have not yet filled out the interest form and you would like to have to attend these meetings, I'll be sure to click on the interest form link and fill that out, or you can give one of my team members, Jordan Larson on the CFC team, a call, and I'll put his number in the chat as well. But it is 303-866-3580. Thank you.
Okay, thank you, Christine. Okay, so we are ahead of time, which is not a problem. It's great. Next up is, I believe, Erin, attendance in the hospital.
Thank you, John. I'm actually going to ask Danny Comstock to respond on, but I will just say thank you all for your patience while we work through this. This one was a doozy. And I appreciate all of your feedback and the work that the stakeholder group, the work group did to bring this to us. Danny, go ahead.
Thanks, Erin. As I was preparing to tell everybody or provide an update, I was actually thinking the same thing. Thank you all for your patience. A little bit of context for this topic is the Participant-Directed Programs Unit received a formal recommendation from PDPPC, from you all, regarding CDASS and IHSS attendance back in November of 2022. So typically we like to get our responses back to you all quickly. As Erin mentioned, this was a doozy. This was a big one to research and look into. But the recommendation that came in was a request to ask HCPUF to move forward in developing policy change and procedure to allow the payment of attendance within IHSS and CDASS programs while a consumer is in the hospital in accordance with the CARE Act. You all asked that HCPUF move forward with an administrative change or Medicaid waiver amendment as soon as possible as dictated by CMS. So as we have finally had some time to look into the implications of these policies, we finally have a response for you all. At this, as our response was finally provided today, unfortunately, I was not able to mail out any materials or email anything out for y'all to review. So I will be sending this response out to everybody very soon. So you will have access to review this yourself. But the unit has evaluated this recommendation to allow attendant care to be provided by CDASS and IHSS attendants in the hospital, paid through the member's prior authorized home and community-based services. We consulted with the Centers for Medicare and Medicaid, or CMS, and reviewed the CARES Act referenced in the recommendation. And we also consulted with other department staff who oversee Medicaid policies and payments in hospitals. Section 3715 of the CARES Act allows state Medicaid programs to cover certain home and community-based services. This section specifies, among other criteria, that such services may not be duplicative of or serve as a substitute for necessary or obligatory hospital services. So while the CARES Act does allow for coverage of services in the hospital, the services that are provided cannot duplicate the services that are already required to be provided by the hospital. Hospitals must provide therapeutic, surgical, diagnostic, medical, and rehabilitative services to patients, and hospitals are reimbursed for these services via the diagnosis-related group payment method. And I'm sharing this information with you all so that you can look into these things as well. But the DRG, or diagnosis related group payment method, is a bundled prospective payment that reimburses based on the resource intensity required for treating patients. So with that additional information, the department does not have the federal authority in the 1915C waivers or the state plan under Title 15 of the Social Security Act to permit paid CDASS or IHSS attendant care while a member is hospitalized. The department does not have budget or federal authority to pursue the policy and operational changes requested. In addition, the department does not have the authority to change the department's regulations regarding payment methodology for hospitals. If attendants are paid for services through CDASS or IHSS while the member is in the hospital, this would ultimately be a duplicative payment, which is specifically prohibited within the CARES Act. There are some instances where a hospital may subcontract with entities for staffing needs, and the department acknowledges that this may be a potential solution for CDASS and IHSS participants who aim to provide care in the hospital setting. The department commits to collaborating with stakeholders, including other department staff, the Department of Public Health and Environment, and members to learn more about reported experiences in hospitals. So that being said, we continue to encourage you to share your experiences with attendant care needs during hospitalization by emailing HCPF, so HCPF_PDP@state.co.us with the subject PDPPC attendant care in hospitals. Additionally, we have a listening session that is scheduled for any interested stakeholders who wish to share their experiences directly with the department, and that will be held on Wednesday, March 8th, 2023 from 9 a.m. to 10:30 a.m. Again, this information will be sent to everybody shortly, and that is, oh, sorry, I do have one more piece. We would also like to inform everybody that members may file a complaint with the Department of Public Health and Environment if the necessary services that members require are not provided while they're in the hospital. And we will be sharing more information about where you can file those complaints, but that would be through the Department of Public Health and Environment. So I would assume we have a couple questions or concerns, but that's what I have to share with you today. I saw Robin in the chat and Julie who raised the hand. I don't know who was first.
Let's see. I think Robin might be about something a little different, but Robin, we will get to you. Julie, why don't you go ahead?
I don't think it was about something different, but
Oh,
I
okay.
I had two things. One is, it is possible for someone to make an ADA request if someone is, if there's going to be a likelihood of institutionalization, or, being dead is also like not the most integrated setting. But so I think there's kind of a difference between like an overall blanket approval to say like you can do this whenever for whatever, and situations where someone is really at risk because hospitals don't have staffing. There's also no way there's no way when someone isn't being properly staffed, or when someone is unable to communicate, because like a hospital might not have an accessible call button or whatever, or someone might be in a state where they can't communicate, to address that. So I would just say that I know for a fact that it's possible for an ADA request to be done, but clients need to know that and know how to do it. So my concern is, once again, there are workarounds, but if you don't have the right advocate and the right information that is kind of hoarded, no one else knows about that. My other concern is just for the department to know. I got a call from someone doing some national research and had been doing research about 1135 waivers. And she called me because she said that she had used some search process. And what she got back is that Colorado Department of Healthcare Policy and Financing allows attendants to be paid while someone's in the hospital. And she called me to say, is that true? And I said, no, it's not. But that's coming out in some search, and it has to do with the COVID and your 1135. So I think someone at the department needs to figure out how that's happening and fix it, because that, again, this is just, again, a national organization. And this person, again, knew that a search might not be accurate, so called me to verify, but other people might not.
Thanks, Julie. Great feedback, and I'll look into the 1135 information. So I think Robin was next.
Right. Frankly, not surprised. I guess my confusion is why other states came to a different conclusion, that it wasn't a duplication of services, in that hospitals provide acute care and waivers provide long-term care, and those are two very different things. And I know, and I know you've gotten some incredibly compelling testimony that hospitals aren't doing it. I mean, they're absolutely not providing long-term care. They don't have the staff and they don't know how. So, and we've experienced it ourselves. So, you go into the hospital, you're in this huge crisis, your husband's dying, and I'm supposed to call you? I guess, and hopefully he doesn't die from lack of care. Well, I'm getting in touch with you. I remember the last one was, Memorial Day weekend, and you guys aren't around. So what were we supposed to do for 3 days? And so when I asked the hospital, they said, you're supposed to private pay an attendant to come in if you want one-on-one care. My husband gets one-on-one care at home, approved by you guys. The hospital doesn't provide one-on-one care. So I'm really confused by your conclusion that is different than conclusions of other states, that is different from the call you and I were on when we talked to folks from CMS. So I'm really confused why you guys came with a totally different conclusion than other states and CMS themselves. And the other is logistically, you're putting people's lives in danger unless we can get prior approval on a case-by-case basis. And I'm okay with that as long as everyone knows that's possible. But it has to be prior approval. You can't do it after the fact. And filing a complaint after the hospital kills my husband really isn't going to give me any comfort whatsoever. So those are my comments. And I know they're snarky because that's kind of how I'm feeling about their conclusion.
Thanks, Robin.
Robin?
Don't need to apologize for snarky. I think we all talked here that this is all passion, right? This is passionate, important stuff. And I think Aaron Thatcher has a couple additional comments that might be able to answer some of your questions or concerns.
Okay, I'm gonna just go. So a couple of things. Julie mentioned the 1135 or like the search. So in our Appendix K, which we basically threw everything that we could think of under the sun into our Appendix K, which was our emergency waiver flexibilities for COVID. So attendant care in the hospital is in there. We have talked about this at length internally for years. And I think there's definitely a need. And we, at the end of the day, we've got a lot of testimony from people who have direct experience with what this looks like. I think the reality is here, like, we aren't the hospital policy people and we aren't the hospital payment people. So I think our middle ground right now and our olive branch to you all as our stakeholders is to connect people who are really dealing with this, and it is a life and death situation at times. And it's not something that we can really plan for or expect or, have approved in advance or, after the fact, who knows. But we want to make sure that those stories, those testimonies get to the people managing the hospitals. Because they really are concerned that if needs aren't being met, then hospitals are being paid for services they're not providing. That being said, I think the allowance and the CARES Act to have this potential flexibility, as long as there's no duplication, is interesting. I think, we're interested in looking at it. It's just a much bigger issue than just it being in the waiver and somebody's care plan. It really does come down to a lot of hospital payment methodology issues, which I am not an expert at by any means. So I think what I would suggest is if you do have a testimonial and you'd like to share verbally in the meeting coming up in a couple weeks or next week, no, 2 weeks, please do so. And on a side note, like I've been there as an AR and as a parent in the hospital providing care that no one else is doing. I get it. I totally get it. And I think my team is really interested in finding a common ground, but we need to connect people with the right entities. So, that being said, I know we have some other people who wanted to comment and thank you all for all the work you've done and what you continue to raise as, a pretty significant issue.
Thanks, Aaron. Next up, we have Kurt Wolf.
Hi, everyone. I actually just went through this 3-4 times in the last 6 months. I filed a big complaint with the first hospital, basically leaving me without a call button. For those of you who don't really know me, as a C3, 4, 5 quadriplegic, I cannot move my shoulders. I had call buttons thrown on my lap as here, call for food when you want it, to change a channel, you name it. It was embarrassing, and degrading to say the least. Won't name the hospital, but I filed a pretty big complaint with them. Also, Julie mentioned the call button. There's other services as well, like bring me different change of clothes or bring me other stuff that I can't have someone do. I have to have a caregiver do it. Now, with that all said, I did talk to my case manager about that. She did a lot of good things as far as giving me permission on a limited basis. And with all due respect, I think the department or someone read duplicative services that the hospital is supposed to provide. And I'm not going to go off on and on about what they're supposed to do versus what they really do. And the fact that we're complaining about this right now, I think something's been read into this. And to do what Robin said, other states have said it's okay and it should be done. So I think we got kind of blown off on this proposal, and I'm a little upset about it. And I think we will take this to the next level if we have to. So anyways, and yes, press your complaints, but I'm really curious where those complaints go, because I never heard back anything about my concerns from two of the last hospitals I had to address. So, all right, enough of that said, but I really think we need to consider how to figure out how to make that work with caregivers, especially high need care people like myself, and especially for AIs who are really in a difficult situation.
Thank you, Kurt. Next up is Nathan.
Thank you. Listening to all those details, it almost sounded to me like the department was not denying the actual ability to provide those services, because they stated very clearly that it is for services that are provided, therefore duplicated. Therefore, it almost sounds like it's inferring the problem lies with the policy of either a hospital individually or collectively, if there's an organization that basically presents those rules or regulations that these hospitals follow here locally. And the solution then may be rooted in our group here, reaching out to either the individual or collective hospitals and calling for their attention to the matter, in that we'd like to assist them with resolving this mutually between the two groups so that it does not become a bigger problem. Because as we've already stated today, collectively, there is, without a solution, definitely further progression in matters that may become legal issues in the very near future. And I think that both parties, and certainly on the part of the hospital, who's always looking to forego any kind of liabilities by wrongdoings or ignoring factors, I think an invitation and a more forward progression requested with them to directly address the matter, it may be a priority of this group.
Thank you very much, Nathan. This is John Barry again. Obviously a very active conversation here. I'm tracking all the pieces, seeing if I haven't missed anything. I want to make sure everyone who wants to speak has a chance to. I'm not seeing anything further. Aaron or Danny, am I missing anything? Anything more you want to say?
I don't see any other hands up, but I do want to just say thank you all for the feedback and just for sharing your testimonials. And I know we received quite a few testimonials in our PDP inbox, and I appreciate all of that as well. I'll be putting the listening session details in the chat. I did read them off, and we will also be mailing that information out as well. And I think Lorraine just raised her hand.
Yeah, thank you. I put a question in the chat. I was just curious as to the department's comments regarding the comments and contributions about retaining staff when somebody is in the hospital, and then how that translates into a transition, having those caregivers on call and ready to work right away, and avoiding a rehab facility after the hospital. Again, maintaining staff in today's workforce is really, really difficult. So now we're going to be in the hospital and the staff is not paid if they don't have that PTO. So they're going to have to look for other work or other clients to serve, and then the patient might lose their caregivers. And I was curious what the department had discussed regarding those comments.
Thank you, Lorraine. I don't know, Erin, are you able to speak to the continuity of care concerns, or is that something that we'll need to bring back?
Thank you. I think, gosh, continuity of care is such a huge thing. Making sure that people who are admitted for a procedure or an illness, when they are discharged home, they have the support they need. I feel like that's a pretty large topic. I would say at this point, if you're interested in sharing your experiences, please come to the stakeholder meeting or submit a testimonial. Again, my hope is that we can get in front of the hospital people who really are, I wouldn't say unfamiliar with this concept of care not happening in the hospital setting, but we want to make sure they hear from you. And so if you feel inclined to submit a testimony or come to the meeting, I think that's a good first step. At the end of the day, like we need to make sure our outcomes are good for our members being served, in whatever setting they're at or in. And, it's a highly complex issue. So, the bottom line for us, I think in this setting here is that this recommendation that was submitted, like really falls outside of our jurisdiction in the waivers and in our authority at this moment. Is there a possibility that could be discussed at a later date? I think for sure. But we will be sending out the official response shortly so that all of you have a chance to look at it. And I welcome all of you to come to our meeting. Thank you.
John, I have one more thing from what Erin said and what was said earlier, as well as what Nathan said.
Okay.
It was very clearly presented that it cannot duplicate services. What it means is it can't. So what's if it's not a duplicated service? It doesn't sound. I know the hospital is not all encompassing. When I'm in intensive care, no problem. Someone watching me 24 hours a day. When I went into the next level down, I had a cold blue because someone would answer a call button. And I'm telling you, that's why it's so important. It's clear, duplicated services only. But if you need someone that's not duplicated, call your case manager. And I had gotten permission for certain situations. I'm not saying that's right or wrong. I'm saying that's what I did. But I think we got kind of blown off on what the department can and can't do based on what Medicaid said versus what the CARE Act said. So I don't think the state really looked at both venues on that. And I think we came back with a general flat answer. And I'm very disappointed in hearing that. And I think people need to be more proactive in being upset about it and realizing that that's not the case. As Robin said, we don't have to wait till someone's dying before we ask for a request of some 113888 Act that you can have care. So I think we need to put some more importance on this. Okay, so done with my rant. My apologies.
Okay, thank you very much, Kurt. We are about at time for the next topic. Obviously, this is a live one, and I'm sure will be continued in one way or another, or probably more than one way. Let's move on to the next item on the agenda, Speedos background check changes. And Jessica?
Yes, thanks, John. I'm going to take the couple minutes we have being ahead of schedule to pull up the document that was included in the materials. I'm going to be talking through this, so those connected online can follow along. Again, this was included in the email materials as well as the snail mail. I'll make it larger because I know that's always helpful. All right, so as many of you know, we've been working on CDASS background check changes for a really long time. And understandably so, this is really important work, and it required a lot of involvement from you all, stakeholders, your expertise, your perspectives. And so I think we are coming to the tail end of this process, although we can totally expect that it to be a living thing to change over time. So where we are with the background check changes for CDASS as of now are, one, that the barrier crimes list, as it was formerly called, is still in the process for finalization. And I spoke about this at the last PDPPC. Just a reminder that because of some feedback from CMS during our waiver amendment process, we do need to make some changes from what was voted in through PDPPC last year. And those are those will be promoted through the HCPF memo series. That memo series has a pretty lengthy clearance process, so that's part of why it's taking a little bit more time than planned. But we fully intend and hope next month at PDPPC to share that updated list with you all. It will retain the name that stakeholders voted in last year through PDPPC. It's a lengthy one, but I think it maybe more accurately and better captures the purpose of that list. So it's the Colorado CDASS Background Check Crimes of High Risk and Employer Hiring Guide. So I will put in the chat the link to the memo series. Or if somebody can help me with the chat, a link to the memo series webpage. That's where any stakeholders can get access to the new list once it's posted, the new hiring guide, and then it'll also be included on our participant directed programs PDP webpage. Again, we'll also share it out with you all through the PDPPC channels and hope to speak about it next month. The second thing is that the exception process for CDASS employers to hire those initially ineligible individuals will remain. And so that process has been in place for a little while now. We've received exception requests, and there is a process to do that. This process does involve a Google form, for better or worse, but there is the opportunity to call me and work through that Google form if that is necessary to complete a request. The request does require a few pieces of information for us to be able to assess the situation. And so that includes a copy of the background check report for the individual that you're seeking to hire, the FMS acceptance of responsibility form, also called an AOR, and then also a safety plan that is specific to this hiring decision. There's a variety of ways you could get that information to the unit. It's outlined in the request form. I'm also happy to talk through those methods one-on-one, either through email or by calling me over the phone. At the end of this, I will include my contact information again for those who need it. So that moves me to the third item, which is the safety plan and kind of more robust oversight. So I think I mentioned this at our last meeting. Some of the changes and feedback we got did require us to think more critically, more thoroughly about oversight and safety planning. I will mention that at the very start of our work group members did support the idea of a safety plan. So we were in alignment there. What we've created are actually two safety plans, and a copy of these safety plans were included in the PDPPC materials. So if you haven't had a chance to look through all of them, I know there were several, I'd encourage you to take some time to do that. The first safety plan is the ASMP, the Attendant Support Management Plan that any new member enrolling into CDASS will complete with Consumer Direct. And part of that plan includes emergency planning. So if you've been through this recently, you might remember you were encouraged to think about, what if there is a fire or when all of your attendants happened to quit, what are you going to do? And just start thinking in advance of what kind of things you can lean on or get access to help you through those situations. There will now be an additional page that is part of that ASMP that will include a very basic question about if your attendant becomes a health or safety risk to you or the member, what do you think you'll do? What can you lean on to support you through that? So pretty basic and not too much of a deviation from the way the ASMP emergency planning is currently handled through that document. The second safety plan is very specific to the exception that a CDASS employer is requesting. And so there are a number of questions that range from, do you understand what made this person ineligible? How will you know if this person becomes a safety risk for you? What kind of supports and resources do you have access to right now that you could use in the event that your safety is put at risk? And so that I believe that is provided right now on the CDCO website. So a person can go and download it from there. I'm working to get it on the PDPPC, the PDP website. And then, as I mentioned, it was included as a copy of it was included in the materials that got sent out. So that's the safety plan. And then the final thing is draft resources. So you might recall from last year conversation around how do we support people in safety planning and asking them about tools and resources and support if maybe they don't know where they can go to get help or to utilize some tools. And so we thought really thoroughly through an approach to draft resources and to create a collection of resources that would be available through CDCO, Consumer Direct for Colorado, our training and operations vendor. And they're currently working on that. They've created some draft resources that the work group will be reviewing this Friday to look through and make adjustments as needed. And then just as soon as those are in good shape, they'll be provided broadly to stakeholders to start looking at and utilizing. And there will be different levels. There'll be just the basics of how to look at a background check report. What does disposition mean? What does felony mean? All the way up to some information about community organizations that help on a more deeper and maybe complicated level. So depending on your interest in diving into the world of background checks and thinking about this, you'd have tools at hand. So I believe that is the end of my overview of where we've come in the process. If you have any questions, I'm happy to take them. And then again, I'll provide my phone number to be reached. So it's 303-866-3504. And then my email address is jessica.corral, CORRAL, @state.co.us. You can also reach out to the PDP inbox. I believe that email address was shared already.
So folks, this is John. If you have a question or comment for Jessica, you can put your name in the chat. John for the queue, for example, or if you are on the phone only or prefer to speak by phone right now to give your name, you can unmute your phone, *6. Anybody?
Yeah, this is Julie.
Julie,
I had my hand up.
Yes, I was just saying that. Go ahead, please.
So I had not seen that form before. I got the packet, the form about the safety plan or whatever. And I think the question about what would you do if you had to fire this person, I thought that was in the training for anyone. Like that, isn't that something that we should always be thinking about with any attendant? So I was just wondering if that is no longer something that's covered in training. And if not, should it be? Because again, I don't know that that's specific to someone with a criminal background. I think that's Like we all have, that's just like a reality of managing this. So.
Absolutely, Julie, and that's a great question. It is covered in training. It's also a dedicated session in Employer 101, and Kurt and Annette speak to that really thoroughly and great. I've been a part of that session. And so, yeah, I think that that's still covered on a basic level. You know, if there are communication, soft skills issues, you know, unreliability with your attendance, how do you manage that? When do you at some point decide this person doesn't work for you and have to go through a termination process? And Consumer Direct is always available to support someone through that. I think the purpose for the safety plan is having that potential health or safety risk at mind. You know, if part of what got a person to the situation is some, you know, concern about one's physical safety or conversations that have become contentious, there might be an element of fear in having that conversation. And so maybe thinking through a different strategy as it relates to termination and getting people the support and resources to think about that maybe in advance of something happening. And that's not at all to say that anyone with a criminal background, you know, is a risk to a member. You know, we want to ensure, and at the heart of this process was to make sure people have the availability of caregivers, and people who want to be in that role can serve as caregivers and not be, you know, discriminated against because of their criminal background. But it's definitely something we have to keep in mind because these individuals, as we know, come into your homes. And so just striking that balance and being thoughtful, getting information and support to our members, I think is the goal of the safety planning.
Thanks, Jessica. This is John. Anyone else comment or, oh, I beg your pardon, go ahead.
Oh, John, I was just going to see if that answered Julie's question.
It wasn't really a question. I don't have any issue with like a safety plan. I was just wondering why we wouldn't be doing that as part of training for everyone, because to be honest, you're always afraid to fire an attendant if they have been with you for any amount of time, because there is a risk of retaliation. I mean, they have access to, you know, all of your stuff. It's so like that fear thing is not, that's just going to be there for everyone. So I hope we're preparing people for that. That was in the original training, and a lot of time was spent on that in the original training. Again, I don't know what it is now, but I just think that dynamic that you talked about is very, very real, and it is for any attendant. And then there's just the practical of, especially if you're not convinced you can get someone quick enough, you know, like, so sometimes there's, yeah, I'm going to have this unsafe person stay until I can figure out getting someone else. And then if the onboarding, you know, if the paperwork doesn't go quickly enough, that's just more and more time. So it's just a delicate balance that people have to negotiate. That isn't to say that you shouldn't do a safety plan if there's a higher risk or whatever. I'm just saying, I think this is the kind of thing to manage this successfully that you've got to keep in your mind all the time.
Totally. Yeah. I'm looking at the clock. I know we still have some time, and I might invite Adam or Katie from CDCO. I don't know if you'd want to share anything about this.
Thought you would. Hi, hey everybody. I'm Adam over here at Consumer Direct. Yes, we do. Julie, really great point. These are covered extensively in the trainings themselves, their importance of management, keeping their attendance. If there's a scenario where they do have to let somebody go, this is that little extra side piece that makes them think at a different level of safety, where if potentially the background check that hasn't happened yet at initial enrollment lends to something that could be a safety risk, what are your plans? Have you thought that far ahead as far as how could you assist in your environment and your hiring practices and have other resources available to you to help in the event of a safety risk specifically that the attendant creates, outside of, I wonder if one day I may have to just fire them for being bad at their job, or having to get an attendant all the time as an employer. So it's kind of that extra little level that we've added to training on top of what you already said, of the importance of keeping on top of hiring that you may need to fire one day and such like that. I hope that also explained it.
Thanks, Adam.
Hey, this is John. Does that bring us to the end of this item, Jessica?
I think so. If there aren't any other questions or comments, I can take, I know I'm on the agenda for the next item, so I can move into that. I've put my contact information in the chat. So again, any questions or comments that might come up for anyone about this after we end today, you can reach out to me.
Anything more for the queue for Jessica on this item, folks? You can raise your hand in the webinar, type your name in the chat, unmute your phone. Okay. Thank you.
Great. Okay, so the next item is the CDASS employer-related information sharing, and this connects back to last meeting and a question that was posed during, I think, the second open forum. And the question, there were two questions, and I'll just restate them for anyone who wasn't with us last month. So it was essentially, how will stakeholders receive new information on elements that relate to our programs, so CDASS and IHSS. And I think an example was family medical leave, and then the Secure Savings Act was brought up as an example. And the second part of the question is, who's responsible for providing direct guidance and training? And so as it relates to the first question, it kind of depends on the thing. So in terms of family medical leave, we have our FMS vendors, PALCO and PPL, involved in creating various kinds of resources and collecting information that they've posted on their website and they send out through their communication channels. It is quite basic as it relates to family medical leave because most of that information comes from the Department of Labor and Employment. And we want to ensure that as a program within CDLE that CDASS employers especially are going direct to the source of information and getting the most thorough and effective informative information. And so a lot of times you may be directed by your FMS to reach out to CDLE directly. The Secure Savings Act is not something that any of us had come across before. So we are looking into this and can follow back up on that one in particular. But there's a lot of really good information on your FMS's websites as it relates to various employment related aspects of CDASS especially. And then our PDP website also has information. So it really just depends on what you're looking for. And I think that if there is feedback from any of you about ways we can streamline the avenues of information or remind people where they can go to get it, we'd love to hear that from you all. We understand that as we're living in a technology-centric world, at some point it can be too much and it's hard to find what you need. So we're happy to look at ways to improve and adjust there. And then as it relates to direct guidance and training, so again, it really depends on the specific item that you're thinking about. Consumer Direct obviously is providing a lot of that CDASS training, and then IHSS provider trainings. And so they have the materials associated to training on their website, or you can reach out to them to talk through that. And then there's a variety of trainings through the FMSs, specifically EVV trainings on their apps and their portal, as well as some informational trainings as it related to sick time. So that is what I would say in terms of that question that we got last month. We are working on getting our PDP website really updated and with a lot more information included. So I would just say keep an eye out on that, because we're hoping that it'll be more of a central place for information sharing and gathering for you all. And that's all I have.
Okay, thank you, Jessica. Were there any comments or questions about that last topic before we move forward? Okay. So we are ahead of time here. So I think in fairness to stakeholders who come in at 2:35 for the breakout rooms, which I believe there are a few who have done that, I think we kind of need to keep that time where it is on the agenda. So I will move to the break at this point, but before I do, Erin, is there anything else that you feel we should mention before we break?
Nothing that I can think of outside of, can we clarify, will the break, will we come back at 2:35 or will we come back a little earlier than that?
No, I think that we can come back at 2:35 and then go right into the breakout rooms. Keep
Okay,
that time as the agenda. That's okay. Well, very good. So folks, we have a little bit longer break than usual, so we will stop now and we will come back and resume the meeting at 2:35 and move into the breakout rooms, which we hope you'll all come back for. So if we can pause the recording, and we will see you all at 2:35. Thanks. We are here for the second part of today's PDPPC meeting. We are going to do our breakout rooms, and I believe, Jessica, you'll see this up?
Yes, as we have for the last several meetings, those connected online should see a pop-up appear on your screen with 3 breakout rooms to choose from. You would just select the breakout room you want to go into from that menu. Anyone joining us over the phone, you'll want to hang back just a minute or so, and we will direct you into the room that you let us know you'd like to join.
Very good. All right. So sorry about that, folks. We are now into item number 12, the EVV improvements discussion. And Jessica, I will turn that over to you. I will be facilitating the mechanics of it, and so we'll have 5 sections that are about 4 or 5 minutes long each. Okay, Jessica?
Yes, thanks, John. Hi again, everyone. Jessica here. We've been doing the EVV improvements discussion for quite some time, so I think most of you should be familiar with it. But again, for those who are new to this meeting, this is a time in our agenda to really just talk about EVV, electronic visit verification, and have an opportunity for participants, and particularly those using our EVV technologies, to share about their experience. As you may have noticed on the agenda, it's pretty well structured, and so we're going to go in that order, 1 through 5, touching upon each of those questions. And then in the parentheses, you'll notice that there's a particular stakeholder group assigned to sharing that particular question, sharing about that particular question. So I do believe we always start with what's going well and opening that up to any CDASS participants who would like to share.
I got an email from Mary Michael saying that that the budgeting feature on the Palco Connect website is leaps and bounds above what we've had. I personally agree. And then she says, I look forward to 1 to 2 key improvements in the near future. Good work, team. This is a great support to the users.
Thank you, Julie. Is there anyone else who would like?
I wonder if we lost John. Looks like we did.
There was a flyer that we got, and I can't remember now if it was with the information for the meeting or not, but it said that there was a change in December, like it was like 99.9%, and then it dipped to like 93%. Is that, are we going to talk about that in this section or somewhere else? Does anyone know what I'm talking about, or was I imagining HICPA flyers again?
There's a lot of HICPA flyers going around these days, Julie. So I think what you mean is the EDV summary of compliance that the EVV team provides, and that was in the materials last month, and then again in the materials this month. I apologies, don't have the information memorized, but I do know enough to say that it has for months now reflected that EVV compliance on a department level for CDASS employers has been really high, in the 99%. And so that indicates that as far as the requirements of EVV and the mandate, those 6 points of data, that is going well, and the department is getting what it needs to demonstrate that the state is compliant with EVV.
Hi, folks, I'm back. Sorry about that. Is there anyone else, any other stakeholders who would like to put in a comment, get in the queue for item number 1? What is going well? You can type your name in the chat, unmute your phone, *6, raise your hand in the webinar. Okay, keeping our time frame going, then I'll move us to number 2. Let me start with Julie. Was there anything else that Mary Michael had communicated that she asked you to read out, Julie?
Yes. So she said that she seconded Kelly's concern that and I'll summarize it because this was an email chain, because Kelly also said she couldn't be here, which is that when you have to document on EVV on the Palco app that you couldn't use EVV, that there is nothing on there for app failure, which keeps us in this loop of not documenting when the app isn't working without people having to go to some whole other thing, which most people just don't bother to do, because you're trying to just get your time submitted, and that not having that reporting within the app is really problematic. So she seconded that. Then she said, I would add that this should be an option on the timesheet portal as well as in the app. And I assume maybe clicking on the timesheet that says something to the effect of, I'm using the timesheet because the app didn't work. I'm not sure that's what she meant, but I think that's what she meant. And then she said, to my knowledge, we are not able to take screenshots of the app on Android phones. Their test team only has iPhones, so they can't test something on Android, which does, like, for a giant multi-state company, that does not make any sense, but that's what she said. So I hope she said she'll listen to the recording, so I hope that I got this right. But she said, the exact words is, to my knowledge, we are still not able to test screenshots on the app of Android phones since Palco made HICPUF and the clients aware months ago that their test team only has iPhones. This is really an embarrassment. This is essential for ongoing error reporting. And I have to agree with that I can't imagine that no one in that large company can find an Android phone and test and see why you can't take a screenshot, because we're always asked to do screenshots. So let me just scroll and see if I didn't see anything additional in this email chain. Did I miss anything, John?
No, I don't think so, Julie. Thank you so much for reading that. Thanks. Are there any other stakeholders who want to make a comment regarding number 2 on the agenda? What is not going well? Robin, I have your name first on that list. Anyone else in the queue? Again, you can type your name in the chat. You can unmute your phone, raise your hand in the webinar. Okay, while we're looking for that, Robin, go ahead, please.
Yeah, I think we all got the scary letter about strikes and EVV. Now I know in this meeting, you've over and over said that manual entries are not strikes, but for the folks who don't go to this meeting, they might think it is. Certainly one of Bruce's attendants was afraid it was a strike. And what happened with the Palco app is that for the last 2 pay periods, every single shift was reported wrong. So the app worked, except it uploaded the wrong times. We have no idea why. So she had to edit 16 entries. So she was afraid that was 16 strikes. And we're doing the usual install, uninstall kind of thing that customer service tells us to do. And we'll see next pay period if, I mean, it was very obvious because she gets here at 9 and every day it said that she was here at 8. So it had added an hour to every single shift. So it was really obvious it was wrong. She manually, made the changes on it. It was fine. But that whole strike thing just strikes, no pun intended, strikes fear in all of us, that somebody's going to get kicked off because an app isn't working the way it's supposed to. So that's what's not working well is, people have to double check times because it's not always accurate. And sometimes it's not accurate every single day. Anyway, and I'm right, that manual entries are not strikes, correct? I need reassurance.
I'm just going to jump in. This is Jillian. Robin, that is correct. A manual entry is not a strike. You got to have a few of them. You got to have a few of them. And even if it's a manual entry, that's still compliant in the state of Colorado. So we'll just leave it at that.
Okay. Like I said, 2 entire pay periods. So, and had no way to report that the app did, there was no way to report on her timesheet that the reason it was manual was because the app didn't upload the correct times. So that's not being reported to anybody.
Okay, thank you, Robin. So we will move on to item number 3. And Jessica, will you start this one?
I will, John, thank you. So as it relates to what improvements have been pursued, at this point in time, after the listening sessions that we had, and I spoke about those last time, and a real decline, I would venture to say a complete decline in any reports we're getting. We aren't actively pursuing any improvements at this time. To speak about the Palco budgeting functionality Julie mentioned, not quite EVV related, but I do understand what Palco has included in their website and know that it, on a budgeting level, solves some of the issues that the portal had in the utilization side of the portal. So I think if people are experiencing that positively, it's good to hear that. And so I would just say, again, we are always pursuing feedback, whether it be about EVV or budgeting, and there's a variety of ways you can provide it, either directly to me through my email, our phone number, our PDP inbox, or our issues form, which is available through Google Forms. And I will stop and take a minute to put all that information back in the chat. Again, my number is 303-866-3504 for people who prefer to call.
Okay, thank you, Jessica. So now I'll turn to the FMSs, and I would ask, we have items 3, 4, and 5. They are very distinct, different, but related, but different questions. So if you can answer one at a time, I'll start with Palco for number 3. If you have anything to say, we'll see if we can do a 2-minute time limit here for each FMS. Palco?
Hi, everybody. This is Nicole from Palco. Am I allowed to respond to the comments the other ladies made?
Well, right now we're focusing on question number 3.
Okay, we
And,
don't, oh, sorry, Don. Okay.
Nope.
Okay, I was just gonna say, we don't really have anything new to report in the last month.
Okay, we'll come to other pieces. Thank you, Nicole.
Okay.
DPL, number 3,
Hey.
question number 3.
Yeah, good afternoon, everyone. The newest thing that I've got to report for PPL, I agree, we don't have a ton of updates surrounding EVV from last month, but we are migrating to the cloud this weekend. So that means that our systems will be down starting Friday. I think it's 3 p.m. Mountain Time or 5 p.m. Eastern. And then they'll be back up on Monday, the 27th at 8 a.m. Eastern or 6 a.m. Mountain Time. So I just wanted to announce that here. Offline mode will be available during that time. So even if Portal is down and the actual, app Time for Care isn't fully up in its normal running status, the offline mode will be available. So you can still save time entries in there and then they'll submit when the system comes back up, or you can go in and submit them if you need to as well. But I just wanted to announce that to everybody so everybody was aware. We did put messaging up in Portal, and then I believe we also have messaging going out that's up in Time for Care, or will be going up, and then there'll be messages going up during the outage as well to let people know. And just a reminder, no need to download or uninstall the app and reinstall it or anything like that during this time. Just leave the app as is, use it in offline mode, and it'll work like normal. So that's mainly it. And then Ashley did drop the help desk information into the chat for everybody to see. I can read the help desk number out. If you have any issues with the app, feel free to contact the PPL EVV help desk. Number is 1-833-204-9041. 1-833-204-9041 is the phone number. Email is ppl_cs_EVV@pcgus.com. Email is ppl_cs_EVV@pcgus.com. And at the tail end of my message here, I think Sandy had just one little thing to add. Sandy Kasperzak at PPL. Thanks.
Yeah, hi, everyone. Thanks, Rebecca. I'll go 30 seconds. I just want to remind, since we were just talking about strikes and stuff too, that with the offline mode working, that you will be in, everybody will still be in 100% compliance, because the offline mode will work once that we move to the cloud. All of those shifts will go in. If people prefer, they don't trust it, or they get nervous about it, you can do a manual entry if you want. But we're telling everybody, just operate like you normally will, and everything will capture. So just to add things that I wanted to make sure.
Okay, thank you, Sandy and Rebecca. So I'll go to question number 4, and we'll start again with Palco. What has been accomplished?
Hi, John. Same
Nicole?
answer. We don't really have anything new to report about for 4 or 5.
Okay. Did you want to take a brief amount of time to say anything in response to what was said before in that case?
Sure. Just to ask if anyone ever has EVV issues, if you just shoot me an email, we can look at it and open a ticket if it's appropriate. And then I think it was Robin who said something about the reasons in the app. I do not believe those are up to Palco's discretion, those reasons. I think that that's something that's set either by HICPUF or SANData. Jessica or Jillian probably know more about that, but those are not something that Palco can just go in and change.
Okay, thank you. I'll turn it now over to Jessica for number 4. Anything?
Thanks, John. Yeah, similar to my last update, not much to share in terms of what has been accomplished. I think Jillian can maybe speak to the EVV compliance side, but again, that's reflecting really well. So I call that an accomplishment, a win, as some have liked to call it. And then again, still working on updating our PDPPC website. We've updated it so far to a point, and continuing to do that, so that it continues to be a resource for people, especially as it relates to EVV information.
Thanks, Jessica. Does that cover number 5 for you, or do you want to tee up number 5 then and say
It kind of covers number 5 too. I'm sorry, I'm not sticking to the structure. Yeah.
No, don't worry about it. I just realized we have left only PPL, so I thought I'd give you a chance, but that makes sense. Okay, so Rebecca, back to you for number 5, if anything. I know you talked about this coming weekend, so that covers that, but anything else?
Thanks, John. Yeah, I don't have anything else at this time concerning specific improvements outside of cloud migration. Thanks.
John, I think Jillian's trying to say something.
Oh,
Yeah.
thanks, Julie. Jillian, go ahead.
Thank you, John. Thank you, Julie. So this is Jillian Estes, the EVV Policy Advisor. And so I wanted to address some things that have come up in the previous remarks. So first things first, I heard about that reason code piece. Nicole, you just kind of touched on it. Those reason codes were historically identified between the department and SANDATA. And so those are not currently open for any changes. And just kind of briefly, anything that doesn't fall into the pre-prescribed options would likely fall under other and would require a note. So I'm just kind of giving that information. So PALCO's software, PPL software, is set up to adhere to those technical specifications. So just to give a little credence to that. The other thing that came up was the question about the 93% lag in the EVV data on that compliance update that we had sent out. So just to kind of give you a heads up, that is not a member behavior thing. I know there's concern out there that, oh my gosh, what happened? What did we do? Members, this is not pertaining, and caregivers, this is not pertaining to any behavior or compliance on your behalf. This was a data transmission thing, and so we expect that that number is going to bounce back to that 99% when we do our data update, and that is coming in the next week. And so, you know, I just want to give you that feedback so that you know this is nothing that has been, again, a member behavior or caregiver behavior. So that's December 2022 of that 93.94%. Thanks for calling that out. The other thing I wanted to talk about, Julie Riskin, you talked about that strike reset notice. For anybody on the call who might have gotten that notice and is a little bit concerned or confused, want to go ahead and clarify that we just wanted to make sure that CDASS members and caregivers, you know, anybody that typically these go to the members and the employer of record, know that we are coming into a new calendar year for EVV compliance. And so we're now in 2023. Strikes reset on February 15th. And it was just a notice to kind of level set for everyone. Hey, we're in a new season of EVV compliance. I have had some calls here at the department and people have been concerned, wait, why did I get this notice? I have a living caregiver. So I just want to kind of clarify for you, we did not discern or discriminate between who got that notice. All CDASS members, employees of record, got that notice. If you have 100% living caregivers, then EVV is not a concern for you, but some members have a combination of both, living caregiver as well as an out-of-home caregiver or just out of home. So we wanted to make sure everybody had that information. That is not a strike notice, no need to worry, but my contact information is on there. You are more than welcome to reach out to me either by email or by phone, and I'll address your questions if you have any additional. I believe that takes care of those points. So I'll stop there. If you have anything else, let me know.
Thank you very much, Jillian. Again, this is John, so I will move us along. Thanks everyone for participating in that. I believe for the next item at the bottom of the page that you see, we have the IHSS subcommittee report, which I believe occurred during the breakout room, if I'm correct. Any reports?
Hi, John, this is Erin. I'm covering for Emily Harvey, who is out on leave until May. So just an update, I think most of you probably know, but if not, she'll be out until May on maternity leave. She had a baby on Friday. So super exciting. If anyone has any questions or issues, they can definitely reach out to our inbox, the HICPUF_PDP@state.co.us, or call us. My direct phone number is 303-866-5788, and we will be happy to help you. In the work group or the breakout room, we were talking about some general survey questions from CDPHE, like what they're seeing, and agencies said it would be helpful to know what the kind of the recent top survey findings are. We talked about some form and responsibilities, as well as what the process is for members who might have a change or reduction in services, what we might need to do related to notices, and if there are cases that we'd like or someone would like us to look into. So overall, a pretty short meeting. That being said, I think, again, if anyone has questions or comments while Emily is out, please feel free to direct them to us. Thank you.
Thank you, Erin. So as you see, folks, at the bottom of the agenda that is visible to you, the CFC CDASS work group, that was covered already. There is no report for the utilization review, utilization management committee. We did cover background checks, and we do not have a report this month relating to NCAPs. So we are now relatively on time still for the Accountable Care Collaborative Phase 3. And do we have the staff with us to see that up?
Hi, yeah, this is Simon Mather from the Colorado Health Institute. I believe that I am up. So let me go ahead and share my screen for the afternoon. Great. Hi, and welcome, everyone. It's great to be joining you all today on this snowy and cold afternoon. Appreciate you having us here. My name is Simon Mather, and I work with the Colorado Health Institute. I'm currently joined by two of my colleagues, Allie Morgan and Kendra Newman, who are going to be assisting today with making sure that they're recording some notes for us, as well as jumping in through the chat and verbally to make some clarifications and things as we go along our presentation. But we're really here today to talk about Phase 3 of the Accountable Care Collaborative. And I realize that some of you might already be familiar with ACC, the Accountable Care Collaborative, and what we mean when we talk about Phase 3, and others may be a little less familiar. And today we'll get everyone on the same page in terms of our work with the department in listening to stakeholders and having conversations around Phase 3. And then we'll present some questions to you all today that we'd love some of your input on as we go through this process of thinking through some considerations for changes to the current Accountable Care Collaborative. So as we get started with that, again, I just want to clarify the role of my organization, the Colorado Health Institute. We are partnered with the Department of Healthcare Policy and Financing, really to be sort of a neutral voice in this conversation. So we're really here to attend meetings such as this one, as well as some other opportunities that we have to hear what folks have to say about the current Accountable Care Collaborative, some of their concerns, and some of the things that they'd like the department to consider for Phase 3. Our team is summarizing that information, and then we're sharing it with staff of the department who are working within some work groups internally to think through what this might look like. And we'll talk a little more about the process and timeline in a moment. So given the fact that we don't have a ton of time with you all today, we're really going to focus on providing a little bit of history and background and context so that everyone, again, understands where we're coming from here. And we'll talk a little bit more about some of the pieces in place as we move towards Phase 3 of the Accountable Care Collaborative. And then we'll have time for a little bit of discussion. We also, and I'll share this again later, we have an online form that we will make sure that you all have access to. We'll put a link in the chat, and then we can connect with the facilitators of this group as well to distribute that via email. So we might pose some questions to you all today. And if we have time, we can take comments during our conversation, or in addition, you can submit comments through that online form as well. And we can be sure to capture your thoughts and feedback that way. And we'll end with some information on how else you can stay involved with this effort. Okay, so I will just quickly provide a little bit of background to you all around the Accountable Care Collaborative, which really has two key roles when we talk about the Accountable Care Collaborative, or the ACC. The first is to really be the delivery system of Medicaid here in Colorado. So delivering cost-effective and quality healthcare services to Colorado Medicaid members across the state with, of course, the goal of improving the health of Coloradans. And really coordinating this regional system of organizations that are responsible for assuring that there's access to physical and behavioral healthcare services for members. For those of you who are able to see my screen, this is a map of the current Accountable Care Collaborative, or ACC again. And you'll see that in Colorado, the current phase of ACC divides up the state into 7 regional accountable entities. And these organizations, or RAIs, are probably some that you're more familiar with. So these are organizations like Rocky Mountain Health Plans, Colorado Access, who help administer and provide support and assure that there's a network of providers for some of these services, physical and behavioral health services. So we're really discussing sort of this system of organizations and that relationship between these organizations and these RAIs in the department when we are talking about the ACC. I won't go through the slide in full, but it is part of the slides that I shared with the department staff today. But again, just want to clarify the roles of the RAIs as they stand right now are to promote physical and behavioral health, to contract with primary care providers, to provide services as a member's medical home, administer and contract the capitated behavioral health benefit, coordinate care, as well as some additional special projects as directed by the department, whether that's practice transformation, looking at certain focus areas, or it might be, again, some more topical and timely situations, such as response to COVID, emergencies, other things like that. Again, this is quite a dense slide for those of you who are able to see it on the screen, but this really just illustrates sort of the changes in the structure of the Accountable Care Collaborative over time. And I should have said this earlier, but we are currently in phase 2 of the Accountable Care Collaborative, which took place started in 2018. So the ACC overall as a structure began in 2011, and in 2018 we transitioned into phase 2, which, one of the hallmarks of phase 2 was bringing together both physical and behavioral health services under one roof, the RAIs. And that brings us to where we are now. So we're currently in phase 2 and we are moving towards phase 3. And for those of you who are interested in what that means in terms of a timeline, hopefully this is illustrative, this timeline I have on my screen, which again will be sent out with the slides. So we are currently at the beginning of our stakeholder activities in developing phase 3. So we, a few months ago, really kicked off this stakeholder engagement, and since then have held a number of meetings and spoken to hundreds of folks about some of their high-level ideas and considerations for phase 3. And we're starting to get more and more granular as we go through this process. This summer, we expect that the department will be releasing some concept papers that will be focused on different topics and really outline some of their proposed and potential ideas for phase 3. But right now, we're just in the process of sort of testing some of those out and getting some initial feedback on what those are. Once those concept papers are released, we will be distributing those widely with stakeholders and members across the state, and then really use that next phase to get feedback on those proposed ideas in the papers. The department will use that to develop a draft request for proposal, which is essentially almost an application for the next group of organizations that might bid to be the next iteration of these accountable care collaborative organizations, our current raised. There will be another round of feedback after that, and then the final request for proposal will go out in April 2024, with the plan to go live on phase 3 on July 1 of 2025. So in thinking about phase 3, a few things that the department is really keeping in mind is building on the strengths of phase 2. So we know that there are some components of phase 2 that have been effective and are working well, and really want to build upon those, but also balancing some of the input that groups such as this one have provided the department over the years, aligning with advances made by other state agencies, and identifying opportunities for improvement. So today I'll share some of the areas where we're focusing our conversations, but really the most important piece of this slide is that we need your input. So while there is a lot of input that's already been gathered, either through the process that we launched a few months ago, we also know there's a lot of historical input that's been gathered, but we also really appreciate having these conversations in meetings such as this one. So before we dive into it, I also just want to take a little bit of a step back again and remind us all of the why. So what really are the goals for phase 3, and why are we going through, this intensive process to make sure that we're getting this right? The first goal is, of course, to improve the quality of care for members, keeping in mind closing health disparities and promoting health equity, improving care access, improving both the member and provider service experience, while managing costs to protect member coverage and benefits and provider reimbursements, particularly in situations where the economy might be changing, to be able to maintain and manage those sort of independent and regardless of the larger economic context. The way that we are thinking about these in terms of the really tangible, on the ground, what does this look like way, are through priority initiatives. And the department has identified 8 priority initiatives that are listed here. I won't go into all of these in detail today, but these are really areas where the department thinks that there are some key opportunities for some changes when it comes to phase 3 of the ACC. And my colleague Kendra can put a link to the ACC phase 3 website, which links to a fact sheet that has some more information around each of these priority initiatives. But this is really the framing that we're using to have some of these conversations. Which brings us to our discussion today, which is how. How are we going to reach the goals within each of these priority initiatives in phase 3? So we, in collaboration with the department, have identified 2 pathways to success that are really intended to link these priority initiatives to those goals that I shared earlier. The first really emphasizing simplifying systems. So how can the department and the ACC standardize and centralize processes to really improve the experience for members, providers, caregivers, other service providers within this broader community, while at the same time assuring that we are still promoting equity and maintaining and improving upon access and quality of care and managing cost. Second, how can the ACC incentivize better outcomes? So that might be better population health outcomes, better clinical outcomes, better process outcomes, better value and quality? How can raised providers, members be incentivized to provide or access care services that improve overall experience and, again, promote equity and close disparities? So I realize that that is a lot of goals and initiatives and pathways, and hopefully it'll start to come together as we have more and more conversations together, but this is really just a way to outline our overall vision and how we're thinking about this. So with that, I want to spend the next few minutes here having a little bit of conversation. And I also just want to share that we, again, will be capturing comments that are shared verbally today and through the chat. But we also, after our conversation today and in the chat, we'll put a link to an online survey, or it's really more of a forum, a comment box, where you can go and submit comments related to our conversation today. So if, I know that this is a lot of information to be presented with on a Wednesday afternoon, so you're welcome to listen today, maybe jot some notes down, do what you need to do, and then if you'd like to revisit this survey or this form in the future, you can use that to submit comments.
Okay.
Sorry, and
assuming I look for comments now at this point. Oh, I'm preempting you. I'm sorry. Please go ahead.
Oh, you're fine. No, perfect. I will just share some of these questions and thoughts on this slide, and then we can pause for a few minutes to take comments. So my first question to you all, these words probably sound familiar. Really thinking about in phase 3, how can we, or the ACC, simplify systems? And some of the proposed ways that the department has put forward as ways to do this involve really coordinating and streamlining Medicaid-related communications to members, as well as streamlining information that really raises awareness and knowledge of services offered to members. And another area where we're looking is within the realm of care coordination and thinking about strengthening and standardizing requirements for different levels of care coordination to ensure that high-risk folks have access to appropriate supports through different transitions or situations. So these are just a few of the many, many ideas that the department has started to think about, but I just wanted to present a few today. So I will pause there for a moment and just get some initial reactions to either the content on this slide or really anything that I've shared up to this point.
Thank you, Suman. So this is John Barry. Robin, I have your name down. Anyone else for the queue who would like to make a comment or ask a question relating to what's currently on the screen? Anyone else in addition to Robin? You can unmute your phone, give me your name. You can raise your hand in the webinar, type your name in the chat. Okay, I'll keep monitoring that, but Robin, go ahead, please.
Oh, hi. So I've been working in the field of disability policy, and I'm a family member and person myself with a disability for over 30 years. And I am so confused about what a RAY is. And they change their acronym and name on a fairly regular basis. And in that context, I guess I've never had a positive experience with Array because I don't even know what they do. So this is what you're telling me they do. They coordinate care. So how are they different than an SEP? And are they the idiots who put my husband into Kaiser without our permission, shared all of his HIPAA information, and now we're getting constant marketing from Kaiser? And I mean, if they want to coordinate his 14 doctors, 8, various and sundry systems, go for it. So I'm confused by what they are. So member experience, not good. No, John, I'm going to finish.
No, I'm going to just ask you not to call people names, Robin. Please don't do any name calling.
So the Kaiser is incompetent a name? A bad name? Okay, so people who probably don't understand the needs of our family. How's that? Is that better? So I want to know who referred us to Kaiser and gave them information. The only people I can figure out is it was something called a Ray. And like I said, I think that goes to member experience. They shouldn't be sharing information. They shouldn't be getting information without it. And care coordination is just mind-boggling because I thought that's what a case manager did at an SEP. So I don't understand how they're different in the world of disability from an SEP. So sorry, you touched off a little bit of a trigger for me.
Thanks, Robin, and appreciate those comments. And certainly, you know, something that we really are hearing, not just from you and from folks in this call, but from other conversations is like, yes, there are all these different organizations and providers, and it's confusing and at times, you know, more than just confusing. So I think that, you know, we would love to hear a little more, I think, through that feedback form about your experience or ways that like the Ray could have more clearly communicated what their role was with you. So yeah, thank you for that comment. And I think that we would encourage you to submit some more information around, and again, not necessarily personally identifying information, we want to avoid that, but if you have general comments about how that experience could have gone differently, I think that that's the type of information that would be helpful in informing phase 3.
Thank you, Robin. Suman, just so you know, we have about three and a half minutes. We have to have a hard stop at 3:50 p.m. Unfortunately, Annie, I apologize for that.
No, that is
I can
fine.
ask for more comments on this. If you want to move to the next one, you can do that. It's up to you.
Yeah, why don't I quickly, I'll just share some of the other comments or questions, I guess comment and questions that I had, and then I'll just wrap up again with some next steps, but this is good. You know, really, we just wanted to get folks thinking about this in the context of phase 3, and we hope to hear more from this group in the future. But again, you know, one of the other things that the department's exploring is how to incentivize better outcomes meaning a lot of different things, right? And a lot of that has to do, like, how can the department better capture and, you know, hold accountable Rays, providers, other folks who are part of this network, and how can they make sure that they're gathering that information from members in a way that is both thoughtful and mindful, but also useful. So it sounds like folks on this call might have some really great suggestions when it comes to that. And again, I'm going to encourage you to use that online tool, which I'm not sure if my colleague has dropped a link for. Perfect. There it is in the chat, because I think that there's a lot to learn from you all and really appreciate, again, the comments so far. So with that, I'm just going to quickly share a little bit of information to wrap up. And again, want to thank you all for allowing us some time today. So this link, if you have comments on really anything that was shared today, feel free to drop it in there. This will remain open. And if you are interested in participating in additional conversations specific to phase 3 of the Accountable Care Collaborative, you can go to this webpage, and there's a newsletter that you can sign up for, and you'll get information about when we are hosting things like public listening sessions, where there will be an opportunity for you to provide a little more input and for us to have a little more of a back and forth. So I will also just end with my contact information here as well. And I believe my colleague Kendra will put that in the chat. And then we can spend the last 2 minutes to take any final comments.
Well, Suman, this is John. Let me suggest, well, let me just tell you that on a regular basis, we have people in this meeting who are not online.
Oh,
they
yes.
don't have a computer, don't have internet, whatever. And so what would be really good would be to give a phone number for people who don't have internet who would like to give you a comment. Is that possible?
Apologies.
on.
It took me a moment to unmute myself. You think I know this by now? Yes, let me pull up my phone number real quick. I do not know it off the top of my head, and I will put that in the chat as we are wrapping up today. But again, thank you. Appreciate that suggestion.
We also ask you to read it out loud because those people now are just on the phone, so they won't be able to read the chat.
Perfect.
So
I can do that. So my phone number is 720-382-7092.
Great. One more time, please.
Yes, 720-382-7092.
Okay.
Yeah.
And unfortunately, I do call time right now. Thank you so much, Suman, for coming and for your team. We will need to move forward. Thank you.
Yeah, thank you. Appreciate it. Thanks, everyone.
Okay. So, folks, we are now at the last item, which is the open forum. And so I am up the, there we go, open forum number 2. So again, this is John Barry. Let me see if there's anyone who has an item for the open forum. You can give me your name in the chat.
Jerry, put me in the queue.
Jerry, thank you. You can unmute your phone like Jerry did. Give me your name. You can raise your hand in the webinar. Jessica, have you down? Anyone else? Trying to pull up the chat here and see. I don't want to miss anyone. Okay, I don't see anyone in the chat right now. We have Jerry and then we have Jessica. Anyone else? Okay, I'll come back to that. Jerry Froney, please go ahead.
Okay. John, immediately after the breakout sessions, today, you and the group went on to the next item on the agenda. However, there were comments, or anytime there could potentially be a comment from the breakout session to the whole group. And in the future, I would request that immediately after we come back from the breakout sessions, you ask if there are any comments from any of the breakout sessions. Thank you.
Thank you very much, Jerry. Okay, and again, any stakeholder, you still have time to give your name. You can raise your hand on the webinar if you want to make a comment. Robin, I have you down. So we will go to Robin and then to Jessica. Robin?
I'll be nice. Don't worry, John. In our group, what we were talking about was expanding consumer direction to other services. So right now, consumer directions only for not IHSS, but CDASS is only for 3 services, and that's personal care, homemaker, and health maintenance. In other places, they've expanded consumer direction to things like housing modifications, respite. I don't know, it could go on, as well as specialized individualized goods and services. So I wanted to let you know what we were discussing, and I'm thinking we probably need to fill out that form to ask for an agenda item of expanding CDASS services into more waivered services. So does that make sense?
Yes. Thank you, Robin.
Do you want us to do that in the form of using the form? Or is this enough?
I think that would be,
there's the form.
I think that would be really helpful.
Okay, I'll do it that way then.
Super. Thank you. So we will move on to Jessica Corral.
Hi again, everyone. I just want to take a couple minutes to provide clarification to my open forum number 1 announcement in regard to our RFP listening sessions. These listening sessions are open to any interested stakeholder, but really the purpose is to hear from program participants. That was what I was trying to get across earlier. We want to hear from you. We want to understand what your experiences have been. And so if there are contractor staff or representatives of contractors, current or potential, who choose to come, I will be respectfully asking them not to actively participate in those sessions, so that we can put forward and center the discussion around participant experience and what those individuals would like to share. Again, there will be a different opportunity for contractors to provide their feedback on the department's approach to the contracts and the requirements they contain, and that information, any that is provided, will similarly be available to all interested stakeholders. So I hope that's clear. And again, I'm always available for questions about this process if there are any.
Okay,
That's
thank
it,
you,
John.
Jessica. So we have about 4 minutes or so. Anything else? There is time for one, possibly two other items for the open forum. We may not have any, that's fine, but we are committed to 10 minutes for this item, so don't want to close it off too quickly. Anyone? Okay, hearing none, I will say a couple of things. One, the link to the recording of this meeting, I will endeavor to get it published as soon as possible, and we'll send it out to the email list. And number two, just point out next month's meeting is on the fourth Wednesday, March 22nd. We start at 1 o'clock. And so with that, I will end the meeting and thank everyone. It's been quite a conversation we've had today. Appreciate everybody. And we will talk to you, see you next month. Thanks, everybody. I'm going to be collecting, I'm pulling